Love it. Welcome to our all-staff meeting for DPH. I know that there are multiple sites broadcasting, as evidenced by this beautiful display here. But I want to welcome everyone in this audience as well for coming and making the time today. And I also want you all to help me welcome our panel. Each of our panelists, we've structured this so that each of our panelists can take a few moments to provide some brief remarks around their work, how it works with the health agency, kind of the priority and vision for where we're going. After that, we'll spend the bulk of our time really responding to questions. Cindy's weekly messages have been encouraging staff to send in advanced questions through dph-connect@ph.lacounty.gov. I'm going to say that slow one more time for everyone who's in a satellite location. As questions pop up in your minds throughout this presentation, please feel free to email those questions to dph-connect@ph.lacounty.gov. We have the questions coming in here, and we'll be adding them to our list. We did have several questions come in advance, so the panelists will take a moment to respond to some of those and then take the questions from the audience. I feel like each of the people up on this stage will be introducing themselves, so I will not take up any more time. I will just take the honor of introducing our fearless leader, Cynthia Harding.
Thank you, Stephanie, and thank you so much to all of you that are here in the auditorium and to all of you that are at remote sites listening to this. This really is a chance for us to share some of the updates from the health agency, and I especially want to thank Dr. Mitch Katz for joining us today and taking the time to answer our staff's questions. It's a chance for you to hear from our bureau directors what's happened really well this year, what are areas that we're going to continue to work on next year, and so we're excited about that, and we hope that Dr. John Sharon is going to join us for a little bit today so you can meet the new director for mental health. We wanted to make sure to introduce him to you. I want to acknowledge Alex Lee, who's here. We've been working closely with Alex Lee on a number of the integration. Alex, stand up so people can see you. And I saw Kevin Lynch come in. Kevin, please stand up. Kevin's organizing IT for all three departments and helping us to be successful in those areas. Did I miss anyone else who's here from DHS that's helping us with some of these integration projects? Okay. I want to jump in and talk a little bit. First, one person a group of people I really have to thank that put this whole all-staff meeting together. And I was chatting with someone before this started, said, I don't think we've ever had a DPH all-staff meeting before. So this is a first, and we're excited about this, and hopefully we can do this at least on an annual basis and maybe even more often if it's warranted. But I want to thank Natalie Jimenez. Please stand. Natalie, David Cardenas, Grace Camacho, and their teams for putting this together. Dr. John Sharon just arrived. Come on up and join us. Dr. John Sharon's the new director for mental health, and we're going to give him a few minutes to talk about the integration of mental health with public health and health services. First, I just want to start by acknowledging there's been a lot of change for the Department of Public Health over the last 2 years. Since Dr. Fielding retired, we have been integrating into the new agency, a lot of change in the board, a lot of change in the external environment with the new federal administration coming in January, a lot of changes on the board, a lot of changes in the state, and so all of this change over the last 2 years has been challenging, but also good in a whole bunch of different ways. Externally, we dealt with some of the most difficult challenges as a department. We dealt with Ebola. We saw the reemergence of infections like measles, and we're now dealing with the Zika. We've been dealing with a rise in environmental justice issues, Porter Ranch, Exide, the Maywood fire. Now we're dealing with issues of hexavalent chromium in the city of Paramount. And all these public health issues have required us to act differently, to act in new ways, to reach out to our partners throughout the county, and particularly to our partners in the health agency, to help us to sort through these issues and to respond as effectively as possible. And I'm incredibly proud of the resiliency all of our staff have been able to demonstrate in the face of so much change that we've seen in the last 2 years. And through that resiliency, I've seen a stronger commitment to our mission, and I've watched you embrace these challenges, and I've watched you prove yourself as leaders in your respective areas of public health, and I appreciate that. And we, as a result of your stepping up to the plate and doing more work in these different areas, we have been expanding our role in tackling environmental justice and are now working with the board on a new board initiative around environmental oversight and monitoring, which will allow us to work in a preventive fashion with communities around potential problems that may arise with industry right up next to residences. And so we're working, and you'll hear more about that from the the Protection Bureau. And then we've been continuing to ensure that our core public health functions continue to address the emergent health concerns that we need to protect the health and safety of our residents. And so I'm very, very proud of our progress as a department. I'm proud of all the work that you all have done. It's been phenomenal. And we're almost on the home stretch for public health accreditation. It's been a long journey, but it's been a wonderful journey, and you all stepped up to the plate. And when the reviewers came from the Public Health Accreditation Board, they recognized the caliber of our staff as one of the most important and successful things that our department had. They praised our workforce for your excellent services, for your ability to address complex public health issues in this environment in which we live in LA County. So thank you for all the incredible work you do. I'm hoping that we will receive accreditation, and we'll probably know in February of next year. We spent this last year focusing on our new role as the public health, the principal community health strategy, a new role that public health departments across the country have embraced and are looking at new ways to do public health work. And so we had a webinar on it, and we've been having trainings for different groups of staff about this new role in public health. It allows us to focus more on upstream determinants of health, focus on systems change and policy work, and looking at ways to work with others to improve the health outcomes in all of our programs for all of our communities. There are a number of examples where we have stepped into this new role as the community health, principal community health strategist. For example, we rolled out our community health improvement plan, and this was a huge effort run by our planning department, creating a roadmap with all kinds of indicators on how to improve health for communities. And it's work that will be taken on not only by our health department, but by a number of others, such as community hospitals, the philanthropic sector, schools, people that are building transportation, and we are reaching out and working with them on these upstream determinants of health to improve health outcomes countywide. We have partnered, as I said, with philanthropy. We did a number of sessions with Southern California grant makers, particularly with their health funders, to talk about if you want to fund in health, here's some things that you can fund as part of our CHIP that will improve the needle and improve health outcomes in communities. And then we have a new initiative with nonprofit hospitals. Nonprofit hospitals under the Affordable Care Act, as part of that nonprofit status, need to use their community benefits for community good. These are dollars that they have. And so a lot of that community benefit money gets spent on uncompensated care, but with the Affordable Care Act and less people having, more people having insurance, less uncompensated care, there were new ideas about how they could spend that funding. And Paul Simon has been working diligently with California Community Foundation and a number of, almost a third of the nonprofit hospitals, to think about new ways they can invest their funds in some of the upstream issues that we care about, education, poverty, housing, to improve health outcomes. I'm just going to jump on a couple others. I'm really proud of the work our Health Impact Evaluation Center has been doing, putting out some really important policy briefs. They recently released the Health Impact Assessment on Measure JJJ, which was passed in November around development, and they are continuing to work on issues around housing. Is Will here? Will Nicholas? There he is. Will Nicholas. Thank you, Will, for your work on that and for working around the issue of housing as a policy that we care about in public health. And then we've been working with the Environmental Health Program on a dashboard and predictive analytics for internal use to be able to optimize our inspection processes and better inform decision making. So that's been really exciting work. So these are all examples of the principal community health strategist, the work of public health as a department as the quarterback to help improve health outcomes in communities. I want to talk a little bit about the health agency and how that has really assisted and helped us as a department to achieve these outcomes. And you know, as we know, the purpose of the health agency was to better serve the clients that come into our doors, to share resources, and to create efficiencies and alignment where it makes sense to improve the processes that we have. And it formalizes one of the core values which we have in public health, which is working collaboratively to accomplish our mission and to protect the most vulnerable populations. And the health agency codifies our ability to do that work in a more intentional and systematic way by having a structure in which we can work with mental health and health services together to better serve our clients in effective ways and to make sure that we get the resources with a louder voice to serve those clients. It allows us to be greater than the sum of our individual parts. And the hope is that we will have seamless experiences for our clients, that we will have better outreach to the hard-to-reach populations to get them into care, to partner better with community providers, and to have more programmatic, financial, or operational support for the public health initiatives that we care about. I think there's a number of areas in the future that we can continue to build on to make the health agency successful and to make our work successful. For example, our community health improvement plan, there's opportunities for us to collectively improve the health of all residents. And in this past year, we've worked on co-location, so there are two of our centers that are now models of co-location of staff, Tucker and Torrance Public Health Centers, and the two teams share duties and work side by side to provide blended services for our clients. Is there anyone here from Tucker or Torrance? Anybody in the audience from Tucker or Torrance? Okay, maybe, maybe not, but anyway, thank you to all of their staff. Is Rachel Flores here? Where? There you are, Rachel. Rachel, I want to thank SEIU and our partners in SEIU, Rachel in particular, for helping us with this co-location and to making this work a reality. SEIU has been working with our department on the co-location and making it as positive an experience as possible. So I really want to thank SEIU for that work and thank Patricia as well. We have a few guests from SEIU here. Thank you. Stand up, and we'd like to acknowledge you for your support and help throughout this. Thank you, Rachel. Thank you, Patricia. I want to acknowledge the support we've had from the Department of Mental Health. When we had all of these environmental justice issues that we've been dealing with this year, the Porter Ranch gas leak, the Exide contamination of families' residential properties, we reached out to the model that Department of Mental Health has for their promotoras, these lay community workers that are trained in dealing with mental health issues, and we were able to train them around the specific public health issues that we cared about. And it's been a phenomenal partnership and a great way to do community engagement. They're very trusted people in the community. They were able to talk about these very difficult issues because of the background they had in mental health and to layer on the training. So it's been a beautiful model that we hope to exploit in a really great way by expanding it and helping to fund their promotoras to increase their reach across the county. So we hope to continue to work that. And then I want to call out DHS and thank them for their support of our helping us to get Measure B funds to expand our work in injury prevention and violence prevention through the Parks After Dark program, an extremely important program that we went from 9 parks this summer to 21. And yes, it's a phenomenal accomplishment. And it was due to the additional funds that we got to do that. So that's the kind of thing that the agency allows us to do where there's a need to think about how we braid our funding in important ways. I think as a department we have a lot to to offer the agency. In fact, we are conducting an evaluation of DHS's Housing for Health program because of the expertise that we have in that area, and we're assessing the effects of that program on health outcomes and service utilization in DHS, DMH, DPH, DPSS, probation, and sheriff, and we hope to have that full report by June of 2018. And our Grant Fund Development Unit is working with all partners in the health agency to identify and implement new ways that we can improve our contract and grant processes. And through the, you'll hear from Wes about the substance use disorder treatment drug Medi-Cal organized delivery system, but we've been able to expand our work because we're working together as an agency in that arena. So I think there are all kinds of new ways that we can collaborate. I think that they will come up organically, and they will also come up specifically as we think about the best ways we can work together, that we can build upon each other's strengths and make, again, the agency much, much greater than the sum of our individual departments. So now I'd like to turn the microphone over to Dr. Katz and have him say a few words, and then we'll hear from Dr. Sharon.
Well, Cindy did a great job, and I want to extend my thanks to all of the people who work in the Department of Public Health for all the work you do every day. Thank you. It's an amazing department that does work that keeps people healthy all over Los Angeles, and that's an amazing thing to say about the work you do. For me, the mission of the agency was always that the core issue is health. Right, that the core issue that public health works on, it's health. The core issue that DHS works on, it's health. The core issue that mental health department works on, it's health. And then what's great about the agency is that we have different tools that produce health, that increase health. So in the Department of Health Services, most of how we promote health is through the care of people who are ill or through providing prevention interventions, many of which are early intervention, vaccination, to keep people healthy. Within public health, most of how you produce health or increase health is through population health methods, focusing on the community and the ways that we can help the community to be healthier. And those work so well together when you're faced with various environmental issues, as you have been, as Cindy was ticking off the various environmental challenges. I was thinking how each one represents a challenge where there's a role for taking care of the people who are affected, and there's a role for how do you prevent future exposures, how do you assess what the issue is, how do you figure out who's affected, who isn't affected. And then if you add in that, of course, environmental exposures are incredibly stressful for people, then you see the amazing role that being able to call on the Department of Mental Health has. So my feeling about us together is that we are so much stronger. And I know people say, well, couldn't you be 3 departments and just, collaborate? And the answer is yes, and we did do that. But ever since becoming an agency, the level of collaboration is much deeper. And I think that's because when smart, committed people work together, all kinds of ideas come up. And there's one that Kevin is working on right now on behalf of SAPC, which is we're working on the backbone of the system, and it may turn out that the answer for the IT actually is in the Department of Mental Health, that it may turn out that their vendor for their system has an answer that would save a tremendous amount of money, all of which would go to services. Right, so whether that one pans out or not, we certainly know that the co-location of the clinical services together in the clinics that Cindy mentioned will result in hundreds of thousands of dollars of additional revenue, which can fund public health programs. And so my sense is that you can't always know what the opportunities are until you put smart, committed people next to one another. You can't sit around the table and say, well, you know, if we work together, maybe we could achieve this or that, because so much is in the interdependence, in the dynamics of understanding this is how it's done in this department, this is how it's done in that department. I know another mental health example is that the Department of Mental Health has a great system of getting consumer involvement through providing stipends, which Department of Health did not have. I don't do public health, and John and DMH has extended that to all of us. Cindy gave several examples of where public health has extended services to DHS. So my view is that we are so much better together. Cindy also mentioned the union collaboration, and you met the great people from SEIU. We've also had good participation in our monthly sessions with the unions, from the Teamsters, from ASME, from UAPD. UAPD is another union that represents physicians in all three of our departments, and that by broadening our collaboration to include organized labor, we are able to achieve more together. A lot of that collaboration is based on saying, yes, it's true that there may be contract issues that have to be worked out in negotiation, but the central issue of the unions and the central issue of the departments is the same. It's our success, right? It's our staff, it's their workers, it's the desire to see the public sector grow and do well, to have people say, wow, you know, I just got great services when I went to a public facility, or wow, did you know that community outreach was led by public workers? So I see that as a huge gain for us, an opportunity. I'm going to finish by dealing a little bit, just because it fits, I think, the general. Two of the questions that are raised within the questions that came forward, I think, fit the general issue of agency, and so I'll try to answer them now. Well, one speaks of the fact that we are a virtual agency. There is no, when the board approved the health agency, there were no positions and there are no budgets, right? I sit in my item as the director of Department of Health Services. There are no additional staff, there is no budget. That was actually by design, in the sense that I'm a big believer that money should go to services, whether they're individual services or they're community services, right, not to bureaucracy. And what I did not want to see happen is I did not want the agency to be some supra-bureaucracy where everything from the three departments would go to this bureaucracy and it would just bounce around and something would emerge. That was not, you know, how I felt about it. My feeling was, well, you have three departments, all of which have the same mission, health. And so we already encompass all of the issues that include the agency. And working together should just allow us to accomplish that much more with our existing resources. And so that's why there were no positions or specific budget attached to the agency. Now, what I think will happen over time, which then goes to another question, is I think there will be some operational collaborations or integrations in order to achieve, you know, greater mission for, if you will, the same price. And I think the easiest one to understand is the one that's already happened under IT, right? Why did we put all of the IT together? Well, because how else could the agency be able to communicate if we have three different IT systems, right? The basic modern communication is IT. That's how this today's session is running on IT. That's how most of us communicate with each other, through our email, right? If we're ever going to be able to communicate about communities or patients, we have to be on the same system, and we're not likely to succeed on the same system if we have three different people producing a system. It has to be one system, and frankly, DHS went through the same thing. 6 years ago, DHS was running almost identical software on 6 separate servers that couldn't talk to one another. So they're both inefficient and costly because we had no efficiency from putting it all together. So IT is the first. The second one, which we've just begun to discussions about, will be capital. So I've asked that Greg Polk head up capital consolidation for the 3 departments. What do I mean by capital? Buildings. The 3 of us, we all have buildings. Like this one, which we share. We have buildings we share. We have buildings that belong to one department, like the building next door, the DPH Central Clinic. We have buildings that are falling apart. We have buildings that need new HVACs. We have buildings that are in the wrong place. We also have some beautiful buildings. The CEO has made clear from their capital point of view that from what the board has asked, all future projects, they want to know if we're going forward, how does this improve the integration of the 3 departments, right? If any of us are building something or we're moving somewhere, are we doing it in a concerted way? And I think the model that the CEO is thinking of, and I think it's a good model, is the Zev Yaroslavsky building in Mid-Valley, right, where the county, with intention, built a building to house the services of various departments to make life easier for the public. And I think that's what we're thinking as well, is that all of our buildings will not last. Several of them have already gone beyond their functional life. How to make them work best is not an easy solution. I don't know if we have people from personnel, from DPH personnel who are on the screen, but you know about the challenges of the building that you work in every day. And we intend to, as an agency, address that and try to get all of us into buildings that are functional, that work for getting our daily jobs done, but that also meet the needs of the public. So I look forward to their more work together. Our integrations will only be in cases like this where there is an overriding mission reason. I don't think you put things together just to build bigger things, right? So if you have a good example is payroll, right? It takes a certain number of people to generate payroll. Doesn't much matter if you have 3 payroll, so you have 1 payroll group, because it takes a certain number of people to get out payroll. And the size of your payroll group depends upon the size of the people whose checks you're processing. There are other things like IT or capital where I think the way we move forward is to have a central organization where some bodies are watching out for all of us and are able to find a solution that works best. So I look forward to the rest of today's session. And John, are you coming up next? Do I have the right order? Yes, so John Sharon, who's a psychiatrist, who's joined us as the Director of Mental Health.
Thanks, Mitch. Thanks, Cindy. Thanks, Public Health. Being a relatively newcomer here, one of the things that struck me most immediately was the opportunity for all of these amazing different departments to work together. I spent the bulk of my career in the VA, which is it's a massive organization. And it has different branches that really kind of emanate from DC that do different but highly related things, and they really don't have the opportunity to collaborate the way that we do here in the county. And I think, I think the agency, by capitalizing on economies of scale, offers us great opportunities. It offers us the ability to be efficient with resources and to use the resources that we can save and generate to do many of the innovative things that we all want to do. At the end of the day, really, what matters though is our clients, is the people that we care for, and they really can't be bothered with the silos of resource that come to each of our departments and the silos of service and function that are tied up in departments. So we really, I think, and I believe we're all pretty much on the same page here, need to leverage the lens of the consumer in organizing the way that we do our business. And I believe that the agency and other departments outside the agency that also have proximity have a great opportunity to move in that direction. One thing which I want to tell you about that I've been thinking about as an example of how departments can work together in a way that for me is kind of refreshing and new, having left the federal government, relates to access to mental health services in particular. Because the fact of the matter is that stigma, which pervades our communities and constrains our consumers, is a massive public health issue. It's a cultural issue. And it's an incredible opportunity for these departments to work together to change that narrative, to develop a new lexicon and a new level of ease for individuals who are suffering to reach out. And how we do that, I think, is really at the conceptual level, but it's something that I take very, very seriously, because it really does constrain not just the health and well-being of individuals, but frankly, our communities and our nation, especially when you look to the populations that we are here for, which are the most vulnerable, the vast majority of whom have suffered significant trauma. And trauma, in almost all cases, really leads to challenges, particularly in the mental health arena. So I look very much forward to partnering, to changing that culture, to improving the ease by which people reach out. That involves education and understanding mental illness. It involves forums for folks to communicate about ideas. And I believe it also involves shared experience and service projects, these types of things. And my goal in this endeavor is really to kind of shift our narrative to one where we look to optimize mental health and not treat mental illness. So with those brief comments, I, again, thank you. It's such an honor to me to have this role and to be at this amazing county with all of these smart, committed people. And I look forward to meeting with you and working with you. And thanks so much. It's really great to be here.
Thank you, Dr. Sharon. Appreciate you joining us today. And we're now going to hear from our first Bureau Director, Dr. Jeff Gunzenhauser, who's also been my partner in crime and serving as our interim health officer in this interim period. And thank you eternally for that.
Partner in crime, all right. So thank you, Cindy. It's been a real pleasure working with Cindy these last 2+ years in these various roles. But anyhow, as I'm looking out at the audience here, I think about half the folks here are in the Medical Director Disease Control Bureau. Can you raise your hand if you're one of our groups? So so nice to you could come. And I could just tell you, as I've looked out at the audience, and I haven't had a chance to see who's looking in there, but as I've thought about it, like half the people here, I've worked very closely with you around some issue this past year, and I can just tell you, it's been an extraordinary pleasure. Most of what we're talking about is change, right? Because there's been a lot of change. There's constant change. We just had an election. There's a lot of implied change ahead of us. But we have a new organization in our department with the 4 bureaus, and we're talking about, what we're doing within those. And now we have this great opportunity we've had in place for almost or over a year as part of a health agency. And it's all about how we leverage these as opportunities for change to do things better. You all know that before I came into this role, I was running our quality division, so that's the lens through which I look at everything. How good is it, and can we do things differently so we can have an impact on the health in stronger ways? So I'll come back to those comments in a minute, but I think the opportunities for change are really great and extraordinary. We really have to take advantage of that. I do just want to highlight a few things. In my bureau, there are 5 divisions. So we've got the Division of Communicable Disease Control and Prevention, Dr. Kim Farley's group. We've got Debbie Davenport's group, Community Health Services, and we have Mario Perez's group, Division of HIV and STD Programs. Since we brought those 3 divisions together in one bureau, at least from my observation about the way we used to communicate and how we do now, there's a lot more communication going on. We meet every week, and we're problem solving a lot. So I think that the organizational change within the department has been, at least from my perspective, very helpful in that way, and I'm going to see a lot of other things improving in that way as well. There's 2 other divisions that we've got. There's a Paul Simon's division, which is assessment planning and quality, and then we also have Dr. Sarah Kurian's division, which is around medical and dental affairs. And the other group that's been extremely helpful to me at an executive level is nursing administration with Noelle and her staff that have stepped forward in so many ways to help our bureau. But as health officer, I've worked with all 3 of the other bureaus on a lot of different issues, and I know a lot of folks are here, so I really thank you for all of that. I just want to highlight some of the things that we've done recently and then come back to the opportunities that I see around taking advantage of the situation better. So I think Cindy already mentioned this, but Debbie has provided really good leadership in working with Christina Gali and Nina Park in solving these co-location issues. This is something long overdue, how it can be that 3 departments could be so closely and not taking full advantage of locations to provide better services in an integrated way. It's just unbelievable. So, and I think what Mitch said it earlier, you just don't know what people are going to find out, what works better until you bring them together. So I know that, this has taken quite a bit of work. People aren't used to this kind of change. We've got to get an MOU and get things in place. But really, in the end, it comes down to creating a situation where we want workers who are delivering services to figure out at the front line what works best. So we're just really moving into that era, and I really anticipate that with co-location, we're going to find all kinds of great opportunities to work together. And I know as we bring mental health closer into that, as an agency, we're going to find a lot of ways to do things very well. Debbie, as you know, has also been working very hard with trying to figure out how to bring in ORCID for us. We're hopeful to get a board letter off early next year and hopefully have that in place in our clinics by next fall. So that's an extraordinary tool that'll be so helpful in so many ways that, again, we can't anticipate. We just got to get there. And finally, we'll have a billing system in place to take advantage of funds that can help us accomplish our mission better. So that's all really great work. The Division of HIV and STD programs, as you know, with HIV, there's really 3 things we got to do: find out who's infected, get them into care, and give them good care. And, it has a tremendous impact in health in so many ways, and Mario's group is doing a great work at that. There's been a recent tool called PrEP, pre-exposure prophylaxis, that's come out, and he's providing leadership on how we can roll that best out in the county to further assure health of folks who are at risk for HIV infection. And I don't know if many of you know this, but we have a huge outbreak of gonorrhea and syphilis throughout the whole nation. We have over 75,000 STDs in LA County every year. The number of gonorrhea and syphilis cases went up by 20% in 2015, and we're working very hard to solve that. And I know we'll find ways to partner with DHS on that. But for right now, we're really focused on trying to how to get the state and other counties more involved around a set of synergistic strategies that are likely to be effective. So that's a really big issue, and I really appreciate all the work that Mario and his team are doing there. In Dr. Kim Farley's group, we've had a number of extraordinary things. Fortunately, Ebola is over. The measles epidemic has long been over, but we've had this outbreak of meningococcal disease, the largest outbreak of meningococcal disease in gay and bisexual individuals ever in the nation, and we've worked really hard to figure out how to do this. It's a really challenging situation because it's not a mandatory vaccination. The population is large. It's probably about 250,000 individuals at risk in our county. How do we reach out to them? How do we extend the vaccine? How do we make it available in ways that are convenient and acceptable to this group? And it's a disease that's really difficult to just end. We've had several months since we've had our last case. Ben Schwartz, who's sitting up here, has helped us keep track of all those cases. But you can go for a long period and then have a recurrent cluster. So this issue about meningococcal disease in this population is going to be with us for a long period of time. And it takes an awful lot of partnering within our department, across the agency, and with so many people in the community to have an impact on that. As you all know, Zika is continuing as a threat. It looks like we got through the year without any local transmission, but we're very concerned about that as a possibility. So we're continuing to redouble our efforts to be as fully prepared for that, because it's obviously going to be here in 2017 as well. So that's a big focus for us. I do want to mention Dr. Simon's division, again, has done extraordinary work. Is Donna Z here? Is Donna's sitting right there. Donna's our accreditation coordinator. She led the multi-year effort to get us accredited. And I just can't tell you enough. She's got all the skills. She's just an extraordinary worker, so thank you, Donna. I know we're going to hear the good news in February, so thank you for all of that. Our Office of Planning, as Cindy mentioned, is rolling out the CHIP. We're going to have a new strategic plan, and I don't know how that small office of just a few people gets all the work done. They do, but it's really great. And of course, our Health Assessment Office, I just mentioned Will Nicholas's report a little bit earlier, but they put out tremendous reports. I think some of you have heard this year the National Center for Health Statistics mentioned that the number of deaths has gone in the wrong direction. In the U.S., it's gone up. So I know Doug and his group is sort of looking here locally at LA what that might mean for us. But all those kinds of assessments about data, how they relate to health and what we do, is done by that group. So we're very, very appreciative of that. And of course, Dr. Kurian's group does all the health alerts out to the medical community, looks at health threats in the medical system itself, and in oral health and a variety of other communicable disease programs. So I really want to thank you as well, Sarah, for all of that. So just to get back, a few things I do want to say. We've really had extraordinary partnership. When you look at how Christina Gali and Nina have worked with Debbie on the co-location issues, we just have had a couple of meetings with Hao Yi and Mark Gali, several of the senior leaders in DHS, about how we can work together jointly on improving health in the jail health or correctional health system. And I think that's going to lead to a lot of great opportunities. Dr. Lee's been doing a great job leading all the priorities for the agency and developing a communication plan for us. And there's all these co-locations, as I said, is another great opportunity. Finally, I would like to say that as much as I observe with this Labor Management Transformation Council and all the work groups that are going on there, I really think it provides a lot of great opportunities for our department. I've been particularly impressed with the clinical improvement teams. That's an established way of assuring quality in DHS, and I think that's something we can do and learn from in our Department of Public Health as well. So anyhow, thanks for this time, and I look forward to hearing whatever questions you may have. I'm going to be followed by Mr. Belomo, who's our Deputy Director for Health Protection.
Thank you, Jeff. And now Angelo Belomo from our Health Protection Bureau will take the mic. Dr. Sharon, do you need to leave? Okay, before you go, we had, can you answer one question? Sure. I think you answered it in your talking points, but we did have one that came in. How will DMH services be more integrated in the health agency?
Sorry to steal your show.
Not at all.
Well, it's a great question. You know, the way I see it, again, going back to our consumers, we really need to drive what we do together to meet their needs. And there are clearly certain environments, certain populations that demand that type of collaboration. So when it comes to individuals who have multiple comorbidities, including mental health related issues, health related issues, substance use related issues, we're compelled to rally around that community together to get the job done. When you look at the incarcerated jail population, when you look at the homeless population, I think due to the conditions, due to traumas of all sorts, starting in utero in many cases, we have an opportunity between these three agencies, with help as needed from other departments, to bring together the resource in a way that is welcoming and digestible to those who require that resource to get on the right path and pursue a life of where they can pursue well-being as kind of as a goal, which is, I think, a new thing for many. Right now, from my perspective, coming in anew, I really want to see us, in a very intentional way, strategically identify our shared added value. It's really easy to look at things like logistics and infrastructure, to support an agency that's doing work as a team. I think when we get programmatic and when we're identifying particular individuals and particular populations in certain domains, it gets more challenging. And my goal as a representative for DHS is to just make sure that we really capitalize on the opportunity to sit together very, very thoughtfully amongst our agency primary partners, but also with different departments, in obviously alignment with the board to achieve better goals than we can independently. So I don't know if that's really answering your question, but that's my thinking.
Thank you very much for joining us, and I've been invited to join along with Dr. Katz. Mental Health will be having an all-staff meeting next Monday, so I'll be joining them and we can share more of our ideas there. So thank you again for joining us, and now I'll turn over to Angelo Bellomo.
Thank you, Cindy. Well, let me just say that going now past a year on this new reorganization, I think all of us have seen and felt the opportunity, the great opportunity that's been referenced here this morning. But I thought it might be a good idea as part of my remarks to just reflect on a couple of accomplishments within our organization. I really want to thank the men and women working within our bureau and our colleagues throughout the department for their hard work and dedication. I think everybody's been pretty much focused, just given the workload and the new issues that we've been dealing with this past year. Everybody's been focused on improving our existing programs, but also asking ourselves, how can we expand our current scope of practice to really meet the needs that our public has? And I just wanted to thank all of you working within the department that have worked with us on this in this past year, from the bottom of my heart, for all the dedication and just the spirit that you've all demonstrated. It's been hard. Our work has been intense. It's repeated itself over many work cycles. Some of our people have worked round the clock to get some of this work done, and it really does demonstrate the finest we have here within the department. And we've got plenty of support from the board, and we've got a management team that, frankly, I've worked with many management teams in the last 40 years, but this is the smartest and the most able group of leaders I've ever worked with. So I wanted to just acknowledge that from the start. The term health protection really imparts an almost tremendous task that's much bigger than any one organization. And so thankfully this is a a term that we share and a goal that we share with many of those working in the various organizations of our department. Within the Health Protection Bureau, though, we do have Terry Williams, our Director of Environmental Health. We have Amaka Oranasi, who leads our Health Facilities Inspection Division. And then we have Stella Fogelman, who is the Director of our Emergency Preparedness and Response. And those are our three divisions. I think Cindy made reference to some of what's occurred this year, but I think many of you might recall what's occurred at the Exide battery recycling facility. It's a smelter, a secondary smelter in the city of Vernon, and it contaminated several miles, a radius of several miles out from the facility. What could be as many as 10,000 homes have been potentially affected by the contamination from the facility. Not just the lead, but the other chemicals that were emitted from that facility throughout its 90-year lifespan. And now we're dealt really with just the residuals here. Now that the facility is closed, we're dealing now with the residuals of having to assess the properties in the surrounding community that are contaminated and then work with the state agencies and the other regulatory agencies to ensure that it's cleaned up and that the health of the public is properly serviced in response to all the exposures they've had. I think we're all pretty much familiar also with the Porter Ranch and Aliso Canyon gas leak, and also more recently, as Cindy referenced, the city of Paramount and the hexavalent chromium hotspot that was detected there. And these discoveries throughout many areas of our county, you would almost think when you read the newspaper articles that there's a new release of some chemical. Sadly, it really reflects exposures that have existed for decades that went undetected. And part of our role in public health and within the Health Protection Bureau, and a priority for the department, is for us to use our position as the health officer to help influence the actions of the regulatory agencies so that we don't have these lapses in the future. Let me just mention a couple of things that have occurred within each of our divisions. First, let me start with emergency preparedness and response. It's really Stella and her team that have kept us prepared and ready to respond to these incidents as they occur. But not only the technological incidents that I've just referred to, but also the natural disasters and acts of terrorism and the biological or chemical agents that could be associated with that type of incident. Stella's group keeps us on the forefront of preparedness, and our response capability has never been sharper than it is now because of the work this division has done. Last year, Stella and her team led the department's efforts in conducting the largest multi-agency, full-scale exercise in the county in over the last 20 years. And many of you, of course, participated in this. This was the exercise that brought in our federal partners as well as the entire Los Angeles region to deal with an exercise dealing with aerosolized anthrax attack. Most of you are also aware of the many celebrated events in the Los Angeles area where our emergency preparedness and response team plays a vital role. They assume positions within the command post whenever we have the Emmys, the Oscars, the bowl games, the Rose Parade. All of the major celebrated events in Los Angeles have our equipment and our personnel on the ground during these events to make sure that if there is an agent released, it's detected in the earliest possible time, and that public health is there to help assess conditions as that may become necessary. So we spend a lot of work on this and a lot of effort, but it's something that our partners have all come to rely on. Within the Environmental Health Division, I just wanted to mention that Terry Williams and the team there have been involved in two major reform efforts that I can think of. The first one dealt with our drinking water program. We are under contract with the state of California to regulate about 130 small water systems within the county. And over many years of poor review within that program, in the last couple of years, Terry, with assistance from Veronica Petrosian and many others within the division, just went through and totally rebuilt that program to the point where in the last review we had with the state, they called it a model program in the state of California. So that's a great example of a reform. The other one I wanted to mention in Terry's organization is the fact that I think many of you know that we have a district surveillance and enforcement program that has as its core work 165,000 regulated units that could include restaurants, housing units, landfills, a number of different facilities. And we also respond to, I think, 25,000 complaints on an annual basis. And we weren't always able to meet our goals for both inspection and complaint response until the group really put their heads together and decided after a very thorough workload analysis that those two functions of complaint investigation and the routine inspections needed to be separated. And we're confident that the changes they've implemented there are going to really show some efficiencies in the years ahead. Lastly, I wanted to mention that our Health Facilities Inspection Division, some of this isn't always happy news. I think that due to gross underfunding from the state of California that is a signatory to a contract that we implement to inspect health facilities throughout the county, that chronic underfunding led to us not really being able to meet the standards that both the state and the federal government have set for responding to these health facilities. And it took a team effort throughout the department. Both Terry Williams and Cindy Harding were involved in this reform effort for at least 12 to 18 months. They're still very much involved, but it was the leadership of Amaka within the Health Facilities Division and her team that actually turned the corner and for the first time ever really met the goals within our contract and in some cases exceeded them. Challenges continue, but let me end on one final point, and that is what we're really seeing now, and Cindy referenced these initiatives, so I'm not going to go back on them, but our work in environmental justice and our work to reduce the risk of toxic emissions in some of our most highly burdened communities, it requires a lot of work. And we are going to the board this year with a request that they've really asked us to submit to make sure that we are able to sustain our continuing work in this area. They see the important role. It's community health strategists, but it's also the role, the general role of the health officer to influence the decisions that regulatory agencies make. So we do expect, for those of you that have been working so hard, we do expect supplementing our workload so that we will make this work sustainable into the future. And with that, I want to thank you again and turn this back over to Cindy.
Thank you, Angelo. And while Wes Ford, our Director of Health Promotion, gets up, I just wanted to do a special shout out to Kay Nagao and Karen Morris for your help in getting that contract negotiated and working with SEIU and our union partners and bringing up our staff to testify on behalf of the important work that we could do if we had a contract that was sufficiently funded. So again, thank you for that partnership. Wes.
Okay, I am going to be quick and brief because I think would be I don't want to interrupt your ability to ask questions because I think probably the more important part rather than me talking to you is you talking to us. So I'd like to get, hear what your questions are. But just to give you a brief overview, I mean, the Bureau of Health Promotion that I oversee has Children's Medical Services, the Office of Women's Health, Chronic Injury, Disease and Prevention, Maternal, Child, and Adolescent Health, and Substance Abuse Prevention and Control. And I want to just acknowledge that, as we've restructured under the bureaus, bringing these 5 divisions together has proven very fruitful because there's a lot of things we've been doing even within the department and stovepipes where we can sort of see where coming together there's a lot of overlap and a lot of synergy in what we can do. And so I think we've made a lot of progress, and I'm not going to go into that piece, but I want to thank Dr. Anna Long and Ellen Idem and Dr. Tony Koo and Wayne Sagita and Linda Aragon, who each all head up one of the divisions, because they have made my life very easy, I have to say, in terms of as we try to do this restructuring. So I really appreciate that. But on top of that, we've also had the agency, the restructuring with the agency that has occurred around the same time as the bureaus. And I wanted to, just spend a little time acknowledging from my perspective the benefits that the agency I have seen has done or has been helpful with respect to carrying out my role, both as the Bureau of Health Promotion, and as you know, the SAPC, or Substance Use Prevention and Control, was also elevated up to the agency level. And I know there's some questions around that, and I'll talk more, when I have questions I can talk more about that, but which was a great thing, because I think, again, it has allowed us, particularly in SAPC, to work very collaboratively with the Department of Health Services and the Department of Mental Health. I did want to mention a couple other things, and Cindy touched on them, was the Parks After Dark, which is, I think, just to give you a little background for those who don't know, it's communities have organized for years around their parks and places to meet and places to do things. And a lot of our neighborhoods, a lot of unsafe neighborhoods, there's a high level of violence and issues around the parks. And the Parks After Dark has gone in and sort of revamped some of that, to the extent that as Cindy said, we've gone from 3 to 21 parks now. The thing that I really wanted to point out, though, is that the satisfaction surveys that have done have shown a 95% satisfaction of people that have been interviewed that access and use the parks where we have started the Parks After Dark program. DMH is going to do outreach to look into how they can provide services through in the parks through a therapy demonstration project. And again, DHS, through Measure B, has provided us the funding that has allowed us to expand. And during the period from 2009 to 2016, there's been an 18% decline in the rate of overall crimes within the neighborhoods, all the way from larceny, theft, assault, and robbery. So I think the Parks After Dark and the collaboration with mental health and physical health have been a great success. One other thing I want to talk about, that where the health agency has been extremely helpful, again, around, I think, SAPC, because of, again, the need to really develop a system of care that hasn't existed historically within the healthcare system. Substance use has kind of lived on the fringes of healthcare. So as we talk about integration, we realize that substance use is an important part, in fact, a critical part of that integration, but it really hasn't been part of the healthcare system. And in part, without going into a lot of detail, some of that has been because we haven't really treated substance use as a chronic disease. We think of it as a moral failure. And as we come to realize it is a chronic disease, it's associated with 83 different kinds of admissions to hospitals. It affects mental health, and mental health affects substance use. I mean, it is going to be a critical partner in the integration process, but part of what substance use is doing is trying to catch up in many ways and build that infrastructure. And I'm trying to think of it as there's, it's a three-legged stool, and SAPC at this point has half a leg. So we have quite a ways to go, and I think being at the agency level has allowed us to move with a speed and a rapidity that we would not have been able to move, particularly as we've implemented the drug Medi-Cal waiver that Cindy mentioned as well. So that's been another area where the agency has been extremely important. One of the other things that we've been able to do as a part of this is through one of our work groups, we've put together interagency flow charts of how, when someone with substance use coming into our different systems, how they flow through the systems to get the treatment that they actually need for substance use, whether they're coming in through a DMH clinic, a DHS clinic, or a DPH clinic. And then not only that, but where are the pain points where people may get lost in the process and get dropped, and important to figure out how do we cover those to make sure that people are getting the right service in the right place with the right intensity for the at the right time. And then not only that, as with anything, when you leave particularly a residential program, a hospital, a mental health inpatient service, how do you make sure those individuals are getting linked into the services that they need to maintain the health that they need to maintain when they get out outside those services? So building those pathways, Dr. Lee, Alex Lee, he was part of that, and it was a real struggle, but we sat down and we really figured it out, and it's been very rewarding to have, I think, as Mitch said, to have the brain power to sit down and do that. I know I couldn't have done it on my own without all those people that were at the table. So being able to draw on that brain trust has been an extremely important part of being part of an agency, in my mind. And the last thing that, I've kind of briefly mentioned the drug Medi-Cal waiver, but the other thing, just since I got it here in my notes, and I'll be quick, I know I'm probably running out of time. Oh, yes, I got to end. Okay, is the screening, brief screening, a referral, ESPERT, the brief screening, brief intervention and referral. I mean, that's been, DHS has built that into ORCID, so everyone gets a screening on that now. And also DMH is working to revise training so that all their providers are getting trained in it. So again, it's another effort. And the last one that I'll mention, which has been extremely important, Dr. Katz mentioned it, was just the backbone of us changing SAPC from just a collection of agencies to a real integrated system of care. Is we need to have a backbone of an infrastructure around IT in order to be able to do that. And so we've come together with IT, their contracts and grants, on the DHS side, on our side, and pulled on that, and it has made things move very rapidly because, again, I will tell you, changing the system of care, and we can talk more about it when you have questions, has been, and I say this, and people, sometimes don't understand, it's been a very, very heavy lift. To go from just an organized or random, just sort of contracting to an organized system of care with all of our partners is a heavy, heavy lift, and we need all the resources we can to make it happen, and I have the back pain to prove that it's a heavy lift. So with that, I am going to end, and I will look forward to any questions you have, and if you have specific questions about any of this, and I'm happy to answer those, okay? Thank you very much.
Thank you. And now, last but never least, David Dykstra, head of our Operations Bureau, the kind of heart and soul of our department, and thank you for your work.
Thank you, Cindy. Good afternoon, Public Health. Good afternoon to my family out in Commerce. If you could wave, if you're still listening, you're still there? Maybe, thinking about it. Well, I may not be a partner in crime. I'll consider myself an associate in crime at this point. Strive to be in the partnership one of these days. Welcome, everybody here. And I also want to say, Dobry Vecher, in the event that any IT specialists in Russia are watching this right now. I thought Kevin Lynch might get a kick out of that one. We should probably hire some of those folks. They're pretty good. They're pretty good. One thing I don't do well, and I've been criticized by my friends before, is I don't really self-promote too well. It's just who I am. And I'm not going to change, but one thing I can do is promote the things we do in operations support a lot better, let you know what we're up to, and really wanted to focus on two things today, two things that I think is close to a lot of people in public health, but two opportunities that with the health agency, I think we're going to make a lot more progress. And I really look forward to 2017 in both of these. The first, which Dr. Katz mentioned, is facilities, something very close to my heart. Since I've been here a little over 4 years now, I've been working with the CEO and now more recently with DHS Mental Health on a number of initiatives around our facilities. We've assessed all of our facilities, and I think Dr. Katz mentioned, a lot of our facilities have reached or some of them have reached their economic life. I can guarantee you a majority of public health facilities have reached the end of their useful life. So a lot of work there, but a lot of exciting work. We're working, like I said, with DHS, DMH on some possible new locations, possibly new facilities. We're going to be working with board offices. I think the great news there is there's a lot of interest in all the board offices to doing something in their supervisorial districts with their facilities, upgrading them, maybe raising them, putting up a new one. So that's going to be work that we work on throughout the year, and hopefully this time next year we'll be able to report back to you. As far as our lab, we've been working with the CEO for a number of years now. We're not only out of space at our current public health lab in Downey, but we need to relocate our environmental tox lab out of Southgate, which is a few miles away, down to the same campus. So we've also been talking to DHS, DMH to see if there's any opportunities there. Again, I think another project that'll be a great project for public health. And last but certainly not least, something very, very close to my heart, we need to get our general staff into better facilities. They need better facilities, newer facilities, facilities that are located in better areas. It makes a lot of sense for us to co-locate programs together. We have a couple of projects already started, one in Torrance, where I think we're going to have 3 programs there, HFID, environmental health, and community health. We're working on something in Panorama City where we might have 3 or 4 programs there. And then finally, we have staff at Adams and Grand and Ferguson. And if you know me, I talk about Ferguson a lot. It's time, folks. We need to get at least a roadmap to plan to get our folks into a better place, a place that makes sense. The other area I want to talk about today is grants. We do a lot of work on grants. We do over about $600 million out of our budget in one type of grant or another. We've been working with DHS Mental Health on this is the second time we've done this. We did the first last year. It's going to be a series of recommendations to the board to really try to reduce the time it takes administratively to take care of a lot of these grants, to do a lot of the busy work. So we're hoping to put together a proposal that we go to the board one time and we get the authority to accept the grant, issue the solicitation, evaluate it, and get contracts out, and not have to go back, do a board letter every time. We'll still be giving them memos along the way of what we're doing, who's getting the contracts in their area and everything. So I think there's a lot of trust that's built up. We do a really good job on reporting and keeping the board informed of our activities. So we're hopeful that this package, along with getting DHS and DMH, we're also accessing each other's master agreements now more and more. So we look forward to that as well. Before Heather starts raising the time signs, I'm going to cut off because I know we have a lot of questions. Anyway, thank you. I want to appreciate everybody out at Operation Support. We do a lot of work for you behind the scenes, but thank you everybody here.
Thank you. So, Mitch, maybe you could take that mic down, and we'll have 2 mics here that we can share across the table to answer questions. We want to take questions from all of you now. We have an opportunity. Heather, who's going to stand up now and let everybody know she's got a mic, as she will, if you've got a question, she'll flag her down, raise your hand. In the meantime, we got a lot of questions that came in from DPH Connect, so we're going to try to answer some of them. And before we do that, I want to remind everybody, when you came in, you got a flyer about the logo contest, the health agency logo contest, either to design a logo or to submit a motto, and I encourage everybody to join in. There's some cool prizes for the winners, and just it's a fun thing to do to kind of submit some artwork or submit a motto about what you think could unite and follow along with this theme of the sum being greater than the individual parts. But let me start then with a question that we got, and then do we have one from the audience? Okay, go ahead.
Well, Katie, I think that the persistence of disparities is one of the most disturbing problems of the U.S. How they've been documented, people have been aware of at least 20 or 30 years, and not a lot of progress has been made, and even in some areas, the economic divide in our country has grown. And I'm not sure everybody is sorry about that. Which is a problem, right? You can't begin to decrease the disparities unless everybody thinks it's a problem. If for some people, the idea that some people get richer and other people get poorer is a good idea, it makes it harder to, as a country, to make a great deal of progress. I think that one of the opportunities that, the agency, obviously, as we talked about, we have no resources beyond what we all are. Right, there's no separate budget, no separate thing, except that it seems to me that the back and forth that can occur between public health and the two, if you want to say, service departments, mental health and physical health, is that we're often taking care of the people who represent that disparity. Not all of them, but almost all of them. And so we have the best access to those people. We probably have the best sense of what it is they need. Public health has the best ideas and the mission of really focusing on the communities in which they live. And that over time, that interaction can attempt to improve things. But I think we have to be realistic about to truly eliminate those disparities, which I believe is possible. You would need economic and racial equality. I mean, that's what it would take to really eliminate those disparities. And that is not, something the agency can do alone.
Thank you for your response on that. And I just wanted to add on the racial equity, our department, along with many other county departments, has been working on an initiative to address racial inequities in the kinds of policies and procedures and programs that we have in the county. And it's an initiative that we're leading along with the CEO's office, with DHR for the county. We've got representatives from the justice departments, from community and senior services. So this is an initiative that you'll hear more about that we are rolling out with other partners to try to address some of this. So just as Dr. Katz said, we need to do better to serve the clients that come in through our door, and then we need to do the work that we're doing in the county and in the communities to address health equities. So I'm going to take one of the questions now that came in from DPH Connect as we're queuing up another one in the audience. So Dr. Katz, I'm going to put you on the spot on this one again. With the election of Trump as president and his promise to repeal and replace ACA, if that happened, how would it change the priorities in the health agency's integration strategies?
Well, I think the easiest part of it is that it would not change the priorities. It might change the strategies of how we achieve the priorities. But I mean, the agency's goals remain the agency's goals, and that's true no matter who is elected. When it comes to the service part, I'm a strong believer that whatever insurance plan you're speaking of, whether it's the ACA or another, people do not get better because of insurance. People get better because of what insurance may allow them to do, which is just a way of saying at the end of the day, it's about the doctors and nurses and pharmacists and the other healthcare professionals on the service side. That's what makes people better. And so our challenge, and many of us have worked in health and certainly in this county before there was an ACA. And what we will do is figure out how to maximize our services, both in the community that are aimed at population health and in the clinic rooms to do a better job. And I do think that the agency will help us because I think there are many inefficiencies in the service side that happen because you get referred from here to here to here that will enable us to provide more care for less dollars if that's what the future holds for us. So, it's very hard to imagine every scenario. I think it's our job as leaders within health to focus on the populations we most care about and commit ourselves to doing the best for those patients and communities.
Thank you. I think we'll take one from the audience.
I think I'll start and turn it over to those. First, I think it's a great idea to think about the way what I take from your question is that, so it is happening, but what you're really saying is, how do we make it happen more? I mean, you yourself are working, are you not on the hepatitis C project? Is it your colleagues? Yeah, not in university. Right. So I have certainly that didn't happen at my level. I don't know whose level that happened at, but someone had the great idea that your group should work with the DHS group that was working on, how to make hepatitis C treatment more accessible. And so another case where I know that it happened completely organically was when the first discussions of Ebola happened. The physician who does women's health in DHS got in touch with the people in public health who were working on this issue, and they themselves figured out what the protocol would be throughout public health and DHS. So it happens, and I think the existence of the agency makes people feel, as you say, more free. But I like the idea of what are the ways, and I wonder if people on the panel have other thoughts on how we might do that.
David?
Yeah, real quick. In operation support, this is something that we run across a few times, and I'm really working with our managers and staff to first think agency before we go up to the county level. So it started really with I think it was the Porter Ranch, when we were really short on PIOs. And so normally we'd go to the CIO and say, could you get us a PIO from their department? But we paused and said, let's first check with mental health and DHS. And sure enough, I think DHS delivered staff for us on a really timely basis. So, and we've taken that in other areas as well. So I think it's just a different mindset is to think about if we need help, if it's something that we can't do, but it's something that needs to be done. Think agency before we would move it up and talk to DHR, CEO, ISD, some others, things like that. So it's just a kind of a different mindset that we're really developing. It's really worked well so far.
I'd like to add just a few ideas. From my perspective as a supervisor and manager, I think that creating the kind of work environment that you're talking about, I use the acronym CARE, C-A-R-E, where it's first of all good communication, second of all there's appreciation of good work, third really recognition of great work, and finally empowering people. And it's hard to get to the empowerment part. There's a lot of things in county work where people don't like to take risks. And we should try to create an environment where people do the right work and perhaps take some risks that are appropriate and likely to do good things for people. We should encourage that. So I know there's a Safe and Just Culture initiative which gets at the roots of these kinds of issues where we want to really empower people to work together collaboratively across the agencies, et cetera. A couple other ideas. I think these CI teams are extraordinary. So, in public health, the way we've done quality is two ways. One, we have performance measures, right? And the second one is these quality improvement projects. But by and large, they're driven top down. The CI teams are grassroots efforts where workers get together and say, hey, there's something here and we should work together. And again, we should really encourage that. And finally, we could, in that little CARE thing I was talking about, recognition, maybe we could create some awards or recognition and say, let's come up with the 3 best improvement projects, across the agency to have people collaborate, kind of like you're saying. Well, there's lots of ways to foster this. There's so many things we can do. Most of us is willingness to do this. Are we willing to do these things? And so we just got to create the right environment where those kinds of things can happen.
Great suggestions, and then I'd just like to add to that, DPH Connect. You got an idea on how we could work better? Send us an email. We read every single one, and we respond back to you. So that's another way to shoot ideas up from the bottom. And then Alex, just raise your hand. Alex Lee's been coordinating our work on the 8 strategic priorities across the agency. So we can do a better job through my weekly emails of sharing with you what's happening with those 8 strategic priorities as we move forward. Okay, let's take another one that came in from DPH Connect, and then we'll go back to the audience. This one I'm going to punt to you, David. Will it be easier to transfer from one health agency department to another?
Of course, the answer is it depends who, right? So, no, it's actually something that came up at our last labor management meeting. I believe My staff's already in contact with DHR. One way is to create a special designation for exams called agency promotional. So right now, sometimes it's run countywide, or it's a departmental promotional. So we're working with them to say, there's a lot of these exams that we have a common interest in, and we want to run it agency promotional. So anybody in the 3 departments would basically be able to apply for it. So that's one thing. Another thing I know we're working on, the 3 HR managers are working on, is we want to get delegated authority from DHR to run exams ourselves that DHR would normally run, because we want to do a little bit more focused recruitment. I think that's another opportunity where you may see some exams come up that it'll be run agency promotional, hopefully, and there's more commonality in the functions that are being done. Again, if you have any other ideas, things like that, we're always open to that. But I think you'll see in the next hopefully 6 months, we'll get something in place here.
Let's go to the audience.
Good afternoon. My name is Dr. Paula Miller, and I'm with the Acute Communicable Disease Control Program here in LA County. My question is, the government currently has the bureaucratic system in place. As we use it, we use the policies and the procedures that are ongoing on a daily basis. So my question to you is, Dr. Katz, how are creative solutions going to be integrated into the county, and what model will the county use to achieve continual change when we're under the auspices of using the policies and procedures that are in place, as well as seeing the types of meetings that are ongoing where only specific types of employees are in these meetings that have the outcome for change?
I might share it with Dr. Gunzenhauser, because I don't know enough about. People have certainly referred to me as the anti-bureaucrat bureaucrat. I don't have a lot of belief in bureaucracy. I believe that people, in part because my observations are that bureaucracy does not always focus enough on the outcome. And I'm very focused on if you're talking about a service, what does a patient need? If you're talking about a community, what does the community need? What is the most effective way to get to the goal? And my view is that to the extent there's a bureaucracy, it's supposed to facilitate that. It's supposed to make it easier for you to achieve the goal. It's not supposed to make it harder for you to achieve the goal. And I certainly don't have any personal problem with taking on, bureaucratic issues, and I have. It's not always fast, but it can be done. I don't know about. Do you want to?
Yeah, Paul, I'm not sure exactly what the issue is, but I think if there's procedures and policies in place that are getting in the way of good work or that don't make sense, we should really surface those and change them to make them effective. I think Dr. Katz is really encouraging a lot of that. I'll just tell you a little story I heard from our labor management meeting last week, where some of you know that our records just go off to these warehouses after a while, and the county understanding was that they would stay there forever. And in fact, the way they're put in there, it's hard to find records that are in there. And I think Dr. Katz or somebody on his staff asked the question, really? Right? And so.
Went to a warehouse and discovered that Gerardo Pineda, who's DHS staff, found that we had records for LAC-USC that were dating back to the 1890s. And we had that because there was at one time a county council opinion that records needed to be maintained in perpetuity because, not for any clinical, because in case the federal or state governments wanted to audit, there was some belief that if they came to audit and they had it, that there's no statute of limitations if they've never actually audited. My view, of course, was if they actually come to audit your records from that far back, you're probably better off without the records. Just make your settlement and say, sorry, we got rid of the records, because I'm sure there's nothing in those records that would support any kind of audit. So, but we're laughing about it, but this warehouse we rent for $1 million a year. And that's just for one hospital. The other 3 hospitals are using a private storage center where they get paid for it's basically per foot that you use. And the community standard is 7 years. That's how long you're supposed to keep a medical record. And after that, you're supposed to shred it. There are other reasons also from the point of view of confidentiality. If anyone, I mean, the warehouse is locked and it has people there, but if anyone ever broke into it, we wouldn't even know whose records were compromised because it's so huge. I mean, you can't imagine if you've never been in a warehouse it's like an airplane hangar with records from floor to ceiling. So all those records are now being shredded, and once it's shredded, down to 7 years, we'll be able to get out of the building, and again, the money goes to services. So, and it did happen by saying, well, but that doesn't make any sense to say that the records have to be kept in perpetuity. It's just not a sensible position, but it did lead to a very nonsensical result. So in that sense, Paul, I very much understand the theory of what you're saying.
Thank you. I'm going to take another question from DPH Connect, and I'm going to use my prerogative to kind of combine 2 questions. These go to Angelo. Please comment on how DPH will take a local leadership role on climate change issues, and could you also comment on how you see environmental health fitting into the health agency priorities?
Yeah. Well, with regard to climate change, I think that, there's a couple of things that we identified as being essential. First, we had to look at our own operations and see what we could do to reduce our footprint. And then secondly, we believe that we need to work with the other sectors to develop both mitigation strategies for them and advocate as the health officer the importance of moving on climate. What I can tell you is when I first started looking at the climate debate, it wasn't public health authorities that were pushing it. It was the conservation movement and air resources agencies who were pushing it. And when it really got traction is when the state health department decided to pull together public health authorities in the state. This was about 10 years ago. And that really gave it traction because we then started to define climate impacts not on, North Pole effects, but what's happening right here in our own jurisdictions. So I think that we have to help agencies and local governments reduce their climate footprint, but we also have to prepare them and help them prepare for the ultimate changes that are in place. We can snap our fingers right now and eliminate greenhouse gas emissions, but the impacts that are already in motion are going to continue for some time into the future. And the second one was how do we see environmental health fitting into the health agency priorities? Right, fitting into the priorities for the health agency. Geez, I'm stumped. I'm stumped on that one, Cindy.
Well, think about what you did around excise.
Well, in that example then, Mitch, we did find that people, they need to have the science behind what the exposures are that they're experiencing. But they also need to have the ability to get health care and health assessment to determine whether their health has been harmed. And Alex Lee has been assisting us in that. People need to have access to care so that if they have been the victim of an exposure, we can detect it early enough and intervention can begin early. And then the second aspect was that of the example of the Department of Mental Health. People want to know what the exposure is, but sometimes they're so wound up in anxiety that they really need help from professionals in the mental health department. And being sensitive about providing those services and utilizing the promotors, which are so excellent at reaching out to the community and working with the community on their concerns and getting information to them. Those are 2 examples of where I think there is some overlap.
And I'll just build on that. I mean, part of our work in the agency is to have better services for our clients, but it's also to help build better communities where our clients can thrive. And I think the work that we do every day in environmental health, whether it's inspecting restaurants, whether it's inspecting housing, pools, water sources, that workforce is doing incredible work to make sure that everybody can live a healthy life in those communities. That's really, really vital work, and it's vital work for our department, but it's critical work for our agency as well. Okay, let's take one from the audience. Okay?
Well, again, I mean, my view is that the goal is health, and then whether you're talking population health or you're talking direct service delivery, what you're talking is a tool for how you achieve that. And so, my view would be, for every health issue, you would determine which thing is the most effective. We were just talking about climate change. Well, there's certainly no effective personal service, health service, that would help with the problem of climate change, right? Climate change can only be addressed through a population health strategy that talks about, what you're going to do in terms of reducing greenhouse gases, how are you going to adapt to it. So other issues, say the jail, the health of people who are in jail, leaving jail. I think there are a lot of overlap issues, because part of how people wind up in jail, has to do with poverty, it has to do with racism, it has to do with discrimination, it has to do with education, it has to do with opportunity. And so in that instance, you apply the tools of population health. So my view is that even if you're talking about a strategic goal that is, improving inmate health and reentry, that there is a role for population health in that. And that conversely, there are ways, another thing I think that incarceration does is I think it leads to family disintegration and increase in foster care, which is certainly not a service delivery issue, right? That's a way that this event affects population health. And where some of the answers are in what are the supports that we provide to foster kids. What do we do about family reunifications? How do we enable, even how do we design the new jail so that people can actually visit, right? I mean, the new jail wasn't really built for either because it was assumed that everybody would be in there short periods of time. It isn't even built with adequate facilities to maintain family connection, which I'd say is very much a public health issue, right? That's not about illness, but yet is integrally related to successful reentry. So I think it's trying to focus on what is the broadest issue and looking at each of the tools we have.
Okay, thank you. Let's go to another DPH Connect question. This one goes to you, Wes. The county's strategic plan highlights making substance use disorder services part of the county's integrated health system. Does this mean that SAPC will reduce or eliminate its external partners that currently serve the community?
Yeah, great question. And I think, again, going back to what I said earlier, the integration of substance abuse into the overall healthcare delivery system is extremely important and I could go on for 5 or 10 minutes about that and just why that is important and the need to integrate that. But there won't be any loss. We're not going to not have or reduce services with our current community partners. In fact, through the DMC waiver, we'll be expanding those services. We build our network, and not only with our community partners, but also with DMH and DHS, because again, as we build a network of care and we have funding to provide for a continuum of services for someone who has a substance use problem, and again, just to help you understand, is the way the substance use system worked is you'd put someone in treatment. Once they were done, you would say, come back when you relapse. I mean, that is not how we treat a chronic disease. So again, under the DMC waiver, there is much more continuum of care, and one of those is case management that will be paid for under drug Medi-Cal that was not a billable service before, and the other is recovery services, where someone can come back and say, I feel like I'm going to relapse, I'd like to get some counseling, or the doctor can just have them come back and check and see how they're doing, and that's a billable service too. So to me, you know, the example I give, it's sort of like diabetes. I mean, we don't get someone's hemoglobin 1AC under control, then tell them to go away until they have a diabetic coma and then come back and see us. Doesn't make a whole lot of sense. So what we're really trying to do right now under the DMC waiver is really build a system of care that is indeed a system, not something that is episodic in care, but it treats substance use like a chronic condition, and that it's a continuum of care. And it's a continuum of care that involves both mental health and substance use, and Department of Health Services, because many people who have a substance use issue, particularly long-term substance use users, are going to have medical problems, and those who also have used for a long time are likely to have mental health problems. So again, we are expanding that network, so I don't see any reduction or not working with our community. Plus, we have to work with our community to also make sure that everyone who has a substance use problem or is experiencing substance use is getting into treatment. And just one last piece, I think we'll even work much more closely with our primary care providers, which I think is critical, because again, part of this is capturing substance use upstream. When someone comes in and says to their primary care physician, I'm having 5 drinks every day when I come home, you know, hitting the bottle and having 5 drinks every day I come home from work. Well, we want to catch that person then and get them into treatment, not after they've lost their job, they've lost their marriage, they're living on the street. I mean, we need to catch people there. We also need to treat people on other parts of the continuum. So we need to think of it as a chronic disease where we can catch people along various forms of continuum, and mental health is going to be instrumental in helping us do that. Primary care is going to be instrumental in helping us do that, and so is DHS. So we need to partner with all of our partners. So I'm going a long way. I'm using this as an opportunity to really take advantage of trying to educate people about substance use, I guess, because I think it's an area where we need a lot of education. So, but yes, we will continue to work with our partners, and we will continue to expand those partners.
Great. Thank you. Let's go to the audience.
Hi, Emily Beeler from Veterinary Public Health. Just to bring it back to climate change, one of the issues in the climate change working group that's been discussed is our own internal impacts on climate change with our commuters, producing a sizable amount of greenhouse gases, our lack of recycling in most of our buildings. It's not clear to what degree is it bureaucratic obstacles or might be cultural obstacles to try to do things that are very prominent, like more recycling, maybe targeted telecommuting at certain times, or not just offering a ride-share program, but strongly encouraging riding together or use of public transportation and efficient use of field work. Is there a way to try to push these issues a little more intensely so that we really embrace climate change kind of within our daily activities?
Yeah, and I think when we talk about changing behavior, we're talking both in the personal sense, like you just referenced, but also in the institutional sense. So to a great degree, information is the first driver that has to get out there. And when people understand what they can do, that it's not a hopeless situation, but there are concrete steps they can do to minimize the contribution to the problem getting worse, as time goes by, and what are the steps they can do to prepare for the ultimate impacts that we are beginning to see. That's important. I think working for sectors is also important because we can't just communicate with the public directly. That's important. It's an important part. But think about it. When it comes to companies involved in water production or in energy production or transportation policy. These are all various sectors that impact on our generation of carbon dioxide and other greenhouse gas emissions. So we have to deal directly with those sectors as well and give them the tools and encourage them to adopt policies which will help push their own behavior and then inform the behavior of their users and the public that relies on those services as well. But I think it's incentives is another part. First, information, and then incentives that could encourage people to move ahead and take steps.
Okay, thank you. I'm going to take one last question from the DPH Connect, and then what I want to tell you all is if you didn't get your question answered, we didn't even get to all the DPH Connect questions that came in, I'm going to commit to getting all the questions answered, so go ahead and continue to send. If you can send your questions by Friday, and then in a future weekly email, we'll have a session where we answer the questions that come in. So continue to send them to DPH Connect. This one I'm going to throw to you, Dr. Katz, because it's come up multiple times to me. It's a two-part question. When will the permanent DPH director be appointed? And will there be a new DHS director, or will the health agency director continue to hold both roles?
Well, both are board decisions. I know much more about the first. There is a very active recruitment going on for a permanent DPH director with great candidates, both internal and external. There is currently a scheduled or preliminary schedule meeting with the board that will happen in December. And I expect there'll be an announcement in January of a permanent DPH director with thanks to Cindy and Jeff who've served in their respective interim roles. In terms of the other, I don't know. I can't really answer the other. I think that the agency, as we've said, is very much an atypical county vehicle, that it's never existed before. It is virtual, right? I mean, if there were a director, that would be the first expense of the new agency, in a sense, right? Because there is, so far we haven't spent any money on being an agency. I guess if there were a agency, that would be your first expense. And again, I have mixed feelings about that, because that is then the creation of a high-level bureaucratic position, which wasn't, in my idea, what we were trying to do. But ultimately, that's for the board to decide.
Okay. Well, there's a couple announcements, so I don't think we have time for any more questions. I just want to encourage folks to continue to send your questions to DPH Connect, and like I said, I will commit to work with this team of amazing leaders to make sure you get the answers to the questions, and we'll put it in a future weekly email. I want to remind everybody that this town hall will be recorded and available for post-event viewing, or maybe just audio. It's just going to be audio, but it's being recorded, so all of this will be available if one of your colleagues didn't get a chance to listen in. And I just want to wish everybody a happy holiday season. Please, happy, healthy, and safe holiday season. Look forward to the amazing work we'll do together in 2017, and thank you for your tremendous hard work in 2016.